members, the members who are online. Good morning, officials. Even the officials who are online. It's 9 o'clock on the dot. We're going to officially start our committee meeting. But before we do that, allow me to give you a moment to reflect. And our moment starts now. Thank you. Colleagues, for record purposes, I think we know the drill by now. I'll ask the members to introduce themselves. I'm going to start with me, and after the members, I'll give over to our learned officials. I'm Emery Boyson, and I'm the chairperson for this committee. Thank you.
Morning, everyone. I'm Benedicte van Minnen, member of this committee.
Good morning. I'm Leon van Wyk, member of the committee.
Good morning. I'm Donita Stevens. I'm a member of this committee.
Thank you, colleagues who are in the chambers.
Greetings.
Go ahead, member.
Thank you, Mr. Chair. Greetings to all. I am Dwayne Jacobs, and I'm a member of this committee.
Thank you, member. And thank you for making the time to join us online. Just on time, Minister. Thank you. Our apologies, and thank you for making it. Minister, we're busy with our formalities. We are done as members. We're going to give over to you, Minister, just to introduce yourself, and then the officials, and then I'll come back to you again, Minister. Thank you.
Good morning, Chair. Sorry, just trying to catch my breath. The stairs. Good morning, Chairperson and honourable members of the committee. My name is Mireille Wenger, and I'm the Provincial Minister responsible for health and wellness in the province.
Thank you, Minister.
And I'll just go.
Thank you, Minister. Good morning, Chair. Good morning, honourable members, and good morning, Minister. My name is Simon Kay, and I am the Deputy Director General in the Western Cape Department of Health and Wellness, responsible for corporate service support.
Thank you.
Incorporating CFO responsibilities. I need to add that.
I remember that part.
Good morning, Chair. Good morning, members. My name is Laura Angeletti Dutwe. I'm the Chief Director of Facilities and Infrastructure Management in the Department of Health and Wellness.
Thank you.
Morning, Chair. Good morning, members. Good morning, Minister. Mulnay van Leeuwen, Director Infrastructure Planning in the Department of Western Cape Department of Health and Wellness.
Good morning, Chair, members and Minister. My name is Gavin Graham. I'm the Director of Infrastructure Program Delivery at the Department of Health and Wellness.
Thank you. Susan, is it custom for you to do your little corner thing?
Chair, it's, wherever you want the gallery to be, we're in it. Hi, members, Chairperson. I'm Susan Smith. I'm the Head of Ministry for MEC Wenger.
Thank you.
Good morning. I'm Gabby James. I'm the MLO for Minister Wenger.
Thank you. We're giving over to the other professionals online to please introduce themselves. No officials online. All right, that is fine. We've also just been joined by Imbowoto Zepondo, by our other members, you just right on time. We're busy with the introductions. So I'm going to start with you, members, just to introduce yourself.
Good morning, Chair and everyone. My name is Rachel van Vogel.
Thank you.
Good morning, Chair. Good morning to everyone. My name is Ayanda Barnes.
Thank you, member. Minister, before I give over to you, just for the record, Minister, we as a committee, we are very much aware of the workload of this department. Myself and Member Van Wyk, we have these interactions, because education suffer the same fate in terms of the workload within the departments. And I think we as a committee, Minister, we're also going to sit down amongst ourselves and really look at the program for the standing committee. and where possible, we're more than welcome to make concessions, and we will follow all the right channels for the necessary approvals, because we do understand that it's not going to be practical, for the ideas we're having, the workload, for you to have your full team every time, and probably by click of a finger to have you and the team again, but we as a committee, we will sit down with our PO and with yourself in terms of what's the feedback from the committee to make sure that we really give you and your team, whether it's alternative, committee meetings, the face-to-face, but we are fully aware that we will run out of energy and I don't know what else because of the workload. So we don't have the answers yet because we have not discussed it as a committee. We will have that discussion and we will revert back to you, Minister, so that really even for ourselves, to fit the program so that there can be breathing space. And at the same time, that service delivery and the professional will continue. We don't have the answers yet, but we will sit down as a committee and then revert back. With that said, Minister, over to you for your introductory remarks, and then the team can kick off. Thank you.
Thank you very much, Chair, and thank you for those considerations from you and the committee. We appreciate that, and if we could jointly come to an acceptable arrangement in terms of your oversight program, that would be wonderful, and we're very willing to support the committee in its work in whatever way that we can.
Thank you.
This morning we're going to be talking to you about our priority infrastructure projects for the current financial year, and quite an in-depth presentation has been prepared for you. And so in the interest of time then, I think I'll hand over to the team to get straight into it. Thank you.
Thank you, Minister. The A team can kick off.
Chair, we're having
technology.
We're having a technological problem in terms of being able to connect into that meeting so that we can share the presentation with everybody online.
I just got the thumbs up because I was going to tell you guys a joke in the meanwhile.
You can still do that because we've got to load the presentation.
No, I'll revert. I'll change my mind because it's a political joke, so I don't want to include you guys.
We appreciate the separation.
All right, over to you guys.
Good morning again. Today we are going to present, as the Minister mentioned, our infrastructure priority for 24-25, and the presentation will deal with the introduction to our health facility platform, and then what actually our work is entailed, and then the priorities as mentioned. One specific focus will be on the mega projects, because you are aware we're currently implementing 3 mega hospitals, as well as the link to the medical innovation and health technology, because our grant in the infrastructure grant actually allow us to acquire medical equipment that is going inside the facility that we upgrade or build and so forth. Then we will give you an overview of the infrastructure progress, projects that are in planning, in design, construction or tender. And then one of our interests at this point in time is to improve the resilience of our facilities relating to climate change, especially on the extreme weather events, but also for the become more independent from energy and reduce the resource consumption in general. Then another comment will be on the safety security, because you are aware of our major issue that we are dealing with the requirement for our facility to be secure for our staff and for our client, but also related to the different area where our facility is and the different level of risk. And then, of course, the plan for improvement, because as a department, and we always try to learn and innovate and try to learn from what we are currently busy doing. Okay, so as a health facility platform, just a general view. We have put in the blue, you will see the number of facilities that are currently available for us for render the service. And then what in the infrastructure planning environment we have done in overseeing the future. So we have a target of 2040 where we will need additional facility. As you know, the demand, especially in the metropole, is increasing because we have additional people coming every year. And then we have still areas that are under service, and we have to address that one too. And of course, there are the issue about the rural, where we have also need for additional facility. So you will see that quite a lot of work that is required to be done. We are dealing with clinics, community day center and community health center that are 24-hour facilities. Then, of course, hospital that we are, level 1 is the district hospital, level 2 is the regional hospital, level 3 is a tertiary hospital, and level 4 is the central hospital. We have only one tertiary hospital, that is the Red Cross Children Hospital. Then the EMS, that is at the emergency medical service basis, where our staff is attending emergency. And then other facilities, under others, we have, in essence, office accommodation. We have store, a warehouse, and, for example, the Pinelands Orthotic and Prosthetic Center. It's a part of that category, and as well as the forensic pathology service buildings. And we have in total 18 of them of forensic pathology labs. Then in relation to what we are doing, we are dealing both with capital projects and maintenance projects. And here you will see the category that we are prescribed to use, because are coming from the National Treasury category for the budgeting. And then in essence on the maintenance, we do in-house and outsource maintenance, and we have 3 workshops where we have chief artisan, engineers, and other technical team that are doing in-house work. But then when the work is a little bit too much for them, we go for outsourcing to service provider like contractor and so forth. The maintenance we are dealing with, of course, looking at especially the health and safety, occupational health and safety items, but also compliance with building regulation and compliance with the fire legislation. That is becoming very onerous, and the legislation is changing quite frequently in the environment. Now I need to change. It doesn't change. Okay, so how do we do it? We are working under a framework that is called Infrastructure Delivery Management System, and is a framework that has been developed with the collaboration of the National Treasury, is applicable to all provinces that are dealing with infrastructure. And the idea was to unify the procurement and the implementation of infrastructure projects across the country. So we are looking at the management of asset, we look at the supply chain management process, and we look at the planning and the budgeting. Just on the right, you will see these are all documents that are prescribed under the infrastructure delivery management system to be prepared every year. And actually, some of them are monthly, and I will tell you which one. But for example, the first one is the user asset management plan. That is actually our infrastructure plan that cover 15 years from us. Every year, we update the user asset management plan, and is a quite a good document to look at if you want to see the way that the infrastructure is planned, and what are the issues that, and what are the priorities, what are the criteria that we are using for prioritize. Then we have 2 documents that are done also yearly, but they are more restricted to the 3 years MTEF budget frame, that is the MTEF. So it's a 3-year infrastructure program management plan and infrastructure procurement strategy. These 2 documents are provided to our service providers, and every year they need to respond to our infrastructure program management plan with the infrastructure program implementation plan. So in our case, we have the Department of Infrastructure, that is our service provider or implementer, and they provide to us the response to the program management plan via the infrastructure program implementation plan. We have also a other implementer via, we call it a management contractor framework, and this is also what we are doing, and then they respond to us in relation to the plan that is done for the 1 year or 3 years. And then, of course, the monthly, quarterly report, we have quite a lot of reporting to National Treasury, National Health, and so forth. And we are using the IRM, the infrastructure reporting model, that is a requirement from the National Treasury, where we put these updates on all our projects that are done in the department. There is also a public dashboard for the IRM, so we are actually updating our internal one, I'm talking about in the government, but then there is also a possibility for the public to address, to see what are the progress on project via the public dashboard. And then, of course, at the end of the year, we also need to comply with the annual report. So we do an annual report, but over and above, we have to do the end-of-year evaluation report, where we look at the performance of the previous financial year. This document is due every year by the 31st of May. And we address the cost, the budget, the expenditure, the efficiency, the effectiveness, the result, and the outcomes, and so forth. All these ones that you see are some of the criteria for us to have access to what we call it the performance-based incentive grant. So the grant in infrastructure has got this possibility that, based on the quality of the document that we provide, as well as the capacitation of our in-house capacity in the department, to give us some scoring. And according to the scoring, if is above 60%, we are eligible to the performance grant. So every year, National Health has got a pot of money that in December decide to divide according to the province, and then give us additional funding. So we have the baseline for the grant, but then if we do this, we scoring more than 60% on this requirement, we can have access additional funding. So last year, I think we got 76 million roundabout as in this current financial year. So I think it's the only grant, as far as I know, that is using the performance-based incentive grant in the country. Then we go to the more in-depth on the infrastructure delivery and management system, and we are actually looking at all the other. So we, on the right with this color, you see that it's all the modules where we have access to, where everything is guided and is clarified in the relation to infrastructure delivery, from the planning to the budgeting to the operational budget. So and then there is a very interesting platform that is called IDMS BOC, that is also open to everybody that want to register, where there are all the people in the government that are dealing with the infrastructure project can have access, can share best practice, can ask questions, and can have access to the documentation. This is part of the IDMS, and it is only in relation to the project. As you know, project is defined for something that have a starting date and ending date, and this is exactly the project flow that we are implementing in the department together with the implementer in this case. So we have the project brief that is called initiation, stage 1. Then we got the concept design, that is stage 2, and you will see there is a check for every deliverable. So at the end of the deliverable, there is a gate, we call it the gate, that is open, approved, and then you move to the next phase. Then there is what technical, the technical or design development, that is a technical design, that is stage 3. Then there is a tender documentation for stage 4. And then after the tender process, you arrive in construction. And of course, construction, it depends in the time on the quality, on the difficulty and the size of the project, but that is stage 5. And after stage 5, we have practical completion, means that the user can have access to the facility, but the project is not completed, so we still have the check that we look at all the handover documentation, where you know, when you build a new building, you need to have access to all the maintenance manuals, the certificate of compliance, and all the stuff that are requirement in order to have the possibility to use the building. And then the last one is the closeout, when actually you evaluate the project, and then you do all the financial completions, and then the project is considered closed. So when you will see in the budget book, for example, that there are a lot of projects, but there is a little bit of money, but it's written stage 6, means that the project is completed from the user point of view, but as an infrastructure, we still need to complete the 2 other phases. Okay, so what we are doing in, as I mentioned already, we have 2 different implementers at this point in time. Actually, one is external, that is the Department of Infrastructure as our implementer, but another one is internal, in the sense that we are ourselves, we are the implementers. So this is a quite innovative kind of way to implement project, is in compliance with the CIDB, the Construction Development Board, and the 50M and the IDMS and so forth. But this is where we are our own, we are responsible for the implementation too, via the management contractor. So what does it mean? We appoint a contractor, usually are quite well-established company, and the company are responsible for the design and construction of the facility. So instead to have the consultant appointed first, and then you go for a tender for a construction company, we appoint one contractor that appoint consultants to do the design, go through all the stages that I show you, and then they can start the construction. So this is quite successful. And we have been implementing this kind of project for the last 8 years or maybe 10 years, and we found that the project can be implemented much faster. And we are using this to prioritize the project that we call it ad hoc, in the sense that the project that are they don't have the long planning requirement or need. So the project that now come up when there is an urgency or emergency and so forth. Then we have the plan schedule maintenance, and then these are the way that we implement it, and I'm not going to repeat. And the last one is about the workshops that I mentioned. And then the emergency, we have quite a lot of emergency to deal with, especially last year when we had the ESCOM problem. A lot of emergency were raised by problem caused by the load shedding, especially in the electrical service, and of course the transformer, and the generators. And then it's done by in-house, our engineering directorate. Okay, these are very high level. This is on the healthcare 2030 policy document that has been done in 2014. And what this is just the high-level diagram on what we want to do in our facility when we start the project. We call it the 5L agenda. So we want to design and build a facility that is sustainable, that has got, reduce carbon footprint, but the issue is related to the utilization of the resources. That must be flexible and adaptable because health facilities are continuously change requirements, especially at the primary health care level, but also in some part of hospital. So we need to be sure that our facilities are flexible and adaptable. Then, of course, creating an environment that is a nice environment for healing environment for our client, but also environmental friendly for our staff and everybody else are using facility. And then, of course, go on what we call a lean design is that actually we reduce timing for design and construction, and we try to work in more collaborative way and integrated. This is, for example, one of the strategy that we implemented via the management contractor. Then, these are our complexity. We have in the middle, I suppose you saw this diagram about our world that is very, very complex. So our facility need to be built and design built in this environment that is extremely complex. So we have, in essence, our philosophy. This is our philosophy in relation to infrastructure planning. And talks about look at the service pressure, of course. We need to monitor the service pressure and we need to prioritize where we experience more service pressure. There is the issue about the backlog, as I mentioned, backlog that is due to the maintenance backlog, but also the backlog to address area that would be they were under service in the past. And then, of course, we need to be sure that we are aligned as possible as we can with the future, that we are be able to plan for facility that can stand for 20 years, 25 years, or even more, like in case of New Somerset Hospital. And then, of course, the resources. We don't have infinitive resources. We need to be sure that our facilities are built and designed in a most efficient and effective manner. And then, of course, the budgeting and all the issue about the security that I mentioned before. So these are actually the high-level view of our criteria, and this will be very well explained in the UMP, as I mentioned, that how do we prioritize projects. So when you will see one project prioritized versus some other project for the next MTF is due to all this complexity coming together and try to give us a direction on which project to proceed. This is giving you an infrastructure backlog, and this is including the maintenance backlog, but also the new infrastructure backlog. So new facilities or new hospital are also here, and you will see that is quite impressive backlog. It's almost 40 billion rand that we are trying to. So let's move to the infrastructure project per se. We have a 3 mega project I mentioned already: Cliffontaine Regional Hospital, Belar Regional Hospital, and Tagebe Central Hospital replacement. Then other priorities, and these are important to focus because this is a way that we prioritize our other capital projects, are related to projects dealing with occupational health and safety, with infection prevention control, with fire compliance. We have, I think we are the owner of most lift in the Western Cape. I think we check with the waterfront, they got less lift that we have. We have more than 200 lift. So you can imagine to maintain, upgrade, is a major work. So you will see a lot of money is going in maintenance and upgrading of lift. And some lift, as you know, the hospital like Roteskier or Tagever cannot work, cannot function without the 50 and more, 66, the Skier Hospital, 66 lift. that at the moment we have. Then, of course, the preventative corrective maintenance. What we try to do is when we build a new facility, we put the money to keep it the preventative maintenance, because it's not point to build a brand new facility and not maintain it from day one. Of course, it's not enough, but at least we try to preserve the facility from a very short decay, very short time decay. For example, I'll give you an example. Kalicha Hospital and Mitchell's Plain Hospital, as soon as they were completed in 2012 and 2013, we put the money to prevent the maintenance and corrective maintenance. And the two facilities now that are more than 10 years, actually they look quite maybe not new, but at least not like Tageberg, just another example, that was completed in 1977, and then maintenance was completely removed at the beginning of the 80s, when there was the big, what we call it, the Black Friday, when everybody left the government, and especially in the maintenance team, a lot of people left. And since then, it was never maintained properly, and this is the reason why we have to rebuild it. Then, of course, now with the ESCOM, but not only ESCOM, actually, this is our resilience strategy, is to implement alternative electrical supply. We got some funding from the Premier Ring Fence funding for the energy, and we put the photovoltaic on hospital, of course, inverters and batteries. Then there are what we call it the geographical hotspot, where actually there are areas where they had in the last few years a lot of people went to live there, and they are under service. One of them is Robertson, where all the seasonal people working in the agriculture, they are coming, and there are a lot of people that the number of population increased quite dramatically over the last 3-4 years. Of course, Kalicha and then Mufuleni, that is another area that there is a growing population and is under service. Then, of course, a few years ago, we started the program in relation to acute psychiatric unit, a big burden in the department and in the province on the mental health issues. And you will see there are some projects in construction, but the next one that we are currently are in planning, in design, is the Carbrema Hospital, that will have a brand new unit that are very specific. The design is purposely designed, and it's a quite a complex building too, because it must be quite we call it vandal proof, but unfortunately we have to deal with very challenging clients in those facilities. And then, of course, the emphasis on the primary healthcare facilities. The department, of course, we are one of the priorities primary healthcare. So we are putting a lot of money in primary healthcare facility, both maintenance and capital. And the new ones that we are currently in planning is a PAR one. Hanover Park is going to be in tender soon for the construction. Is a 24-hour facility. And then we got the Maitland that is also in a very bad condition, in a very utilized area, overutilized facility that required to be replaced. Then other criteria, these are already mentioned, the overutilized and the non-existent due to the past, then the condition of the building, the rapid growth population. What we challenge, we have a lot of challenges is on the sites, especially in the metro. We are actually having quite a big challenge to find the suitable sites. And so when we have insurance that the site is available, we never start the project unless the site is available, because we know that can hamper the good progress on the project. So together with the Department of Infrastructure, that are the custodian, we ensure that the sites are available. And then, so in some cases, we have to prioritize one project versus another because the other one doesn't have a site, and even if they equally urgent. And then, of course, the capacity to operationalize the facilities. We never built something that we become a white elephant that is not utilized. This is a quite stringent requirement from the condition of DORA in the grant. So the department, the National Department of Health comes and check if we have, even Treasury actually, National Treasury, that we have fully operationalized the facility. So this is another criteria. And then the consolidation. This is happening especially in the rural, where we have, for example, the PARL CDC will be the result of a consolidation of two facilities. The same is Robertson. We are trying to consolidate and provide a full package of service in a more purposely built facility, and we consolidate the geographic. Of course, we keep the geographical distance in the metro, and in the rural we use a 5-kilometer radius. That is a national standard that we apply. These are the mega project, and they are quite a complex building. And we were discussing the priorities on this project. As you know, when you do a big infrastructure, you have the three issues that you need to look at: this time, cost, and quality. So and you need to prioritize one versus another, and according to that, you can design or plan your project according to that, your process for implementation. In this case, we agreed that the time and cost is the two priorities. Quality, of course, is important. We will never build something that is not, but we cannot design something perfect and take 10 years for designing. So we need to prioritize the time, and of course the cost that must be effective and efficient. Okay, a little bit of background on this, where we are with this one. I'm not going to read the slides, but you will see this is a quite important project. It's coming from when the hospital, the Mitchell's Plain Hospital was open. If you remember, there was the closure of the GF Juste Hospital. And the GF Juste Hospital was relocated, or the staff in the service was relocated to Mitchell's Plain. The site got empty, and the plan was to relocate or rebuild the GF Juste Hospital as a district hospital on the same site where the old one was. What happened in 2015 is that there was the Healthcare 2030, and the Healthcare 2030 brought also the acute bed plan for that was approved by Cabinet in 2015, where actually the demand for that area, that is Mannenberg and Cliffontaine and the Mitchell's Plain substructure, was for the regional hospital. So the regional hospital was a requirement. So regional hospital is much larger than the district hospital. So in essence, the district hospital like Calicia was designed for 210 beds when it was originally open. Now it's got more beds, but originally was 200 and something. So the idea was to relocate or rebuild GF Juste as a 210 beds on the same site. But due to the requirement of a regional hospital, the number of beds increased. So the demand from the planning team was, I'm talking about the service planning, was to build a 600 beds hospital. We assessed the site, and we couldn't find a possibility to build a 640 beds hospital on the site of GF Juste, because it's a very small site. So we started the launch for the construction, for the finding a site. So since 2015, we were working, and then at one stage there was a big interdepartmental committee that was chaired by the Premier, the then Premier, and at the end we found a site that was, you will see is this one, that is in front of the original site, but there are two schools on the same site. It's a Silverstream Secondary School and Sonderenden Primary. The Sonderende is a Planky school, and so what the Department of Education came and assist us is that they agreed to relocate the Silverstream, but to change it as a school of skills and to build it on the former J.Ust. hospital. So there is a project, unfortunately didn't proceed well because there was a court case and I'm not sure all the details, but I know that is coming construction soon, the School of Skills, so the relocation of Silver Stream will take place in a few years, and then Sonderender that is required to be replaced because it's a Blanky will be moved to Evendal School. So this is the site. It's not I can say it's not as big as we would like, but you will notice the difference between the former GFU's site and the new site for the Cliffontaine Hospital, because this is 7.2 hectares. It's quite tight, I must confess, but we couldn't find anything better for the hospital. So to go back to the regional hospital project, we are currently in concept design, the stage 2 that I mentioned earlier. And then the idea is that we build the hospital in phases. So like we did for Mitchell's Plain and Kalicha, the first phase will be the commissioning of only 222 beds. And then what we call it a bare space, so just a shell to accommodate additional 196 beds. Then in phase 2, when there will be capacity to make operational the 196 beds, we will complete the shell inside, like we did for Caliche and Mitchell's Plain, and we will bring the hospital to 418 beds. And then in phase 3, that will be the last one, there will be additional work that we built on the top of existing one, if I remember correctly, and is going to bring the capacity to 640. So we will not tell you when it will happen because it's depending on the budget availability for the operational budget. But what we can tell you is that we will provide the hospital, commission hospital in 2033. 2033, but we try to shorten the period together with the Department of Infrastructure. As I mentioned, the time is our major leader in the design of this facility, but you will have a hospital only for 222 beds because this is what we can afford to operationalize. Then these are, the budget. The budget, what we did in 2019, we submit what they call it a budget finance infrastructure, or BFI, is a bid that National Treasury run every year between April and June, where they ask for a project, infrastructure project above 1 billion rand to bid, and then you need to prove what they call the bankability, and you must prove that are shower ready and so forth. So we submitted this bid for Cliffontaine in 2019. We received feedback approval in 2020. So the funding for this project is going to be from the BFI channel in the health facility revitalization grant, but we will have as a province, because this is one of the criteria for the BFI project, to have also raising funding to to assist in the costing for the project. So it's actually a joint venture, I would say, between the provincial government and the National Treasury to fund these facilities. Now, I explained already the site, and I'm not going to mention, but the demolition is required by January 2028. As you know, the school needs to start in the new location, and this is related to what the idea is that we keep the Silver Stream empty, and then as soon as Sonderend is also vacated, we will demolish the full buildings. There are some asbestos roof there, so there is additional cost that we have to deal with, but the asbestos is actually present in all our old facilities, and we don't have other options. Then these are a little bit of drawings for the hospital. You will see that on the roof we are planning to put solar photovoltaic. Of course, cannot carry the entire load of an hospital like that, but that at least will help for the electricity sources. Then Belar. Belar is is actually got a different story in the sense that this one is coming from the Tageber Hospital, current Tageber Hospital. The current Tageber Hospital is 1,328 beds. And in the acute bed plan that I mentioned earlier, approved by Cabinet in 2015, there was put the concept that the current Tageberg is acting as, or is functioning as a tertiary, quaternary, that is level 4, as well as level 2, as well as level 1. So under that big building that we have now, you have the 4 level of service that is provided in hospital. So, and the location or the catchment area of Tageberg is actually the entire Metro East. So at that time, in the discussion, the team agreed that actually the service offered by for the level 2 doesn't need to be located where the hospital currently is. So it's better maybe to try to find a site for the new hospital that is closer to the community that is serving. And the idea was right at the beginning to look around along the 300, and then the idea came up. I will tell you the site, how we finalized the site. But then this hospital, we call it unbundling. We are unbundling Tageberg in 2 facilities. One is the Belar Regional Hospital, and we are still discussing what name give to this hospital, because it's not only looking after the Belar community, but as you see, is actually providing services to a much larger, the entire Metro East area. And Belar is the site where the site is. This is why we call it at the moment Belar. And the other one was to keep the hospital as a central hospital on the same site where the current hospital is, but at a much lower number of beds. So this was the history, and this is why we have now 2 hospitals coming from the Tageberg, and there is no regional hospital in the Metro East. That is quite unserved area. So the entire service, regional service provided at Tageberg, and the clients needs to come from very far areas, you know, Eastern Fier, you see Kalicha and so forth, to be able to get service at the current site in Tageberg. So this project is also, we will build it in one phase, because operational budget is available from the unbundling of the current Tageberg, and we will have in total 600, around about 600 beds, and then we are planning to complete this project also in 2033. And this is why we need it, because this is linked to the decommissioning of the Tageberg Hospital. So the 2 new hospitals needs to be commissioned more or less at the same time, in order for the central hospital and the regional hospital. And you know, you can imagine, to have a current hospital that is fully functional, needs to be decanted in 2 facilities, needs to take place more or less at the same time. So we align with this date with the completion of the new Tageberg Center. If I make it too complex, please let me know, because it's very complex, this discussion. But yeah, you can ask me questions at the end. But nevertheless, so we are at stage 2, that is concept design, and we are also having a BFI application for this project. So we also got approval from the National Treasury, and the same discussion I made for the Cliffontaine is applying on the funding side. So how did we find the site in Belar? The original site was a City of Cape Town site, and you see is more or less here where the Pentec station is on the right. But then we found out that this site was a dumping site, so it required a lot of cleaning and to make it feasible for construction. So at that time, a Human Settlement Department came to assist us, and then we started the discussion to provide a site on the Belar area that was at that time and is still now under development. So human settlement, all the building around are actually housing building, but is a very good site in the sense that is very well connected with the station, that is Umbel station, but is also close to the UWC and Siput campus. And then it's got a very good access to the 300. The site is that one on the right. The only challenge that we have is, we have a few challenges on this project, but I'm not going to tell you all the challenges, but the challenge is also like the Cliffontaine, that is a quite small site for an hospital of 600 beds. So technically can be done, but it's going to be challenging. So you will see all the roads around are coming from the development framework that was developed by the human settlement together with the city of Cape Town. The building that you see, the grey one that you see close to the circle, is a pump station that was built in 2018, and we require to be relocated. So we are in discussion with the city, and we are in discussion with the human settlement that now is under the Department of Infrastructure in order to work together on this relocation. And then, and there also the access requires some attention. You will see that there are only residential kind of roads around the hospital, but actually in hospital of this size, we required at least double lane access from both sides. So, but these are discussions that we are having with the city and the Department of Infrastructure. So we identified this, maybe go back to this one. So the left one where the circle is, it will be the access to from the visitor, staff, clients, and visitors. And then on the right, you will see that other entrance will be utilized for goods and services and emergencies, not emergencies, ambulance. The ambulance are coming from the circle, but for in case of emergency exit. But it will be the, we call it the service yard for the hospital. Okay, this is a very high level preliminary. I already said to the team, I don't like curved walls. So they are looking on that because curved walls create a lot of maintenance challenges and it's very difficult to build. So we don't want to have a curve, but this is just an idea of what we are looking for the hospital, for Belar. And Tagebel Central. So the Tagebel Central is started many years ago. Was in the Department of Transport Public Works at that time. We appointed the CSR to do a report in 2005, and then the CSR gave us quite a comprehensive report, and then at the end the recommendation was this hospital needs to be replaced. So it's not suitable. So since 2005, this hospital is not, proper. It's not actually a good building to work in. But so the Department of Health registered the project as a mega project in 2009, and then in 2013, the department agreed that it must be done by a private-public partnership. Because of course the sizing of the project is not something that can be done in-house with funding from the provincial government or even national government. We are talking about currently the budget for the project is between building and medical equipment is around about 11 billion rand. So we started the feasibility study. And we presented in 2018 to Provincial Treasury and National Treasury. National Treasury gave us feedback. We worked on the report, and then COVID came in 2020. So we stopped to work for a couple of years on this project. And then we start again the feasibility study. So what the Provincial Treasury did at that time in 2018, because seeing the issue that the building required urgent maintenance, was to provide us a ring-fence allocation for maintenance of the Tiger Bear Hospital, the current one. And what we put in place a lot of projects that are looking at, we call it the nerves of the hospital. So the mechanical installation, the electrical installation, the sewerage, the water, and so forth. So we are actually utilizing this funding to keep working this hospital, especially from the service point of view. So now these are other dates that are shared on relation to the PPP per se, but the most important part is that we got the approval in the PPP legislation. You got a series of approval that needs to come from the National Treasury. We got the first one that is called TA1 in November 2022. And then after that, we work on the some sort of RFQ, RFI, sorry. Is an RFI? Yeah, RFI, the request for information. So to see what was the appetite of the market for this kind of project from the private sector point of view. So we got this market sounding exercise that we did last year when we had quite a lot of financial institutions that came and we had discussion with them and see the, we call it bankability of this project. And we were quite satisfied. We had more than 21 interviews, discussion with the financial institution that they were wanted to know about this project. They were keen. They will be keen to participate in the PPP when it is gone out to tender for the development. And then what also we did, we look at the full site, and maybe I must go to this. Sorry, these are other dates. Let me continue with this the Tiger Bear PPP before I go to the other one. So this is the central hospital. There will be 893 level 3 and 4 beds, so high specialty. A similar size of Groteschia. So Groteschia is around about the same size of this one. So the two big facilities will be similar. The PPP is for the design, construction, and the operation of some soft facility service for 20 years, including the maintenance of the building. And after 20 years, the service provider will give us back the facility in the same way that was founded, so since that will be fully maintained and so forth. The soft facility service that we are looking at is the cleaning, for example, the security, and some other that they are nothing to do with the clinical service. So the clinical service will be rendered by the Western Cape government, and then some soft facility management service will be by the private party. The PPP excluded the enabling work, and I will explain you what enabling work required for this project. The bulk infrastructure is in a sense the plug where the hospital needs to get the electricity, water, and sewerage, and so forth. Of course, health technology. This was a discussion that we had and we debate because medical equipment is a very I can say, is very costly to maintain. And we learned from the experience of Albert Lutuli, where health technology was part of the PPP and became completely unaffordable by the provincial government of KwaZulu-Natal. So we excluded, means that the service provider is not responsible for the acquisition and the maintenance of medical equipment. So that will be our responsibility. And then the Block X. The Block X, for those who know Tiger Bear, is the radiation oncology. We have 3 bunkers or 4 bunkers there. And we thought that it's not cost effective to relocate the bunker because it's extremely costly construction. And the facility actually, we maintain properly the Block X. So in relation to the costing, you will see that the 2033 dates come up to all the 3 facilities. So our aim is to have this decommissioning of the big hospital in at the same when the 2 hospitals are ready, and then they can be First, we need to decommission the central hospital, and then will be decommissioned to the regional hospital. But that decommissioning part is still work in progress. So we are not, we don't have a full understanding how it can work, because it's quite complex plan. So now the site in Tageberg is quite a big site. It's 64 hectares. And if you go now to Tageberg, you will see it's a quite desolated place with this huge building that is the current hospital. So what we did, we appointed a team of urban designer to assist us to do what they call it urban design framework, and see how can we make this facility more alive and more welcome in the environment where we are, to make it more feasible for the, to use as a human, this big site. So you will see, this is just high-level development framework that is coming. You will have on the left the white building with the H is just the place where the new hospital is going to be. It's not, of course, the design, because that is the responsibility of the service provider. We are not going to provide a lot of information. So this is the new hospital, the left one. Then you will see where the green with the trees, planting a lot of trees, is the parking base. We have quite a high level of requirement for parkings. So we are going to have this parking area with a lot of trees. Then the building in the back. For those one that knows the hospital, you will see there is a big change to the building. We want to open up the central core of the current building, that is the demolition of Block C and Block A in the current hospital, of course, after the decommissioning of the two hospitals. And we need to demolish the Block E and Block F, that are the wards that are similar to those one that you see that are J and G on the right. So the idea is to repurpose this building. We are looking together with universities, we are looking with the private sector, we are looking with the other departments to make this building to convert in other, to use other function. So other function can be training function, research function, accommodation function for student or for medical staff, because remember the University of Stellenbosch Faculty of Science is right in the back. So there is a lot of connection with the University of Stellenbosch, but also the other universities, all of them, Western Cape and Seaport and even UCT. They are quite interested to come on board in this big redevelopment. Then the red building or the pink building you see are the existing one, and the rest are the potential new construction. We are looking at the idea to develop some sort of health park where you have training, you got research, but then you can also work with the private sector for maybe some labs for and so forth. Another thing we want to look at is to create a wellness hub for all the people working in this facility. So, for example, the construction of a gym or other retail areas and so forth, some shops and so forth. The building on the right that are behind the pinky one are going to be the new Cape Medical Depot. We are busy planning the relocation of the Cape Medical Depot from Chapini Street to Tageberg. Is a project that is quite advanced. We need just to find the money. It's costing like 300 million. And the idea is to go for a design and build. So to appoint a contractor that knows how to build warehouse, because in essence it's a warehouse, and to speed up the construction. And then we will have this purpose-built warehouse for the pharmaceutical. We have also non-pharma warehouse on the same site. And then we have office accommodation, and then we have, of course, the laundry, the regional laundry, and we have forensic pathology head office and EMS head office. The idea is to create this health hub that is got the tertiary hospital, but then everything else that is on that site is in some way linked to the health department and the health service. The blue one that you see are retention ponds that are getting the water, storm water. So we have a major crisis with the storm water in the hospital at the moment. So the idea is to create these retention ponds for to become, like we did for Mitchell's Plain Hospital. Then from the mega project of medical innovation, of course, we are trying to look at the future. It's quite challenging because we don't know where the diagnostic imaging medical equipment is going, the surgery, robotic. As you know, we have the Da Vinci robot at Groteschiera in Tageberg, but maybe in the future there will be other robots that can do the work assisting the surgeon and so forth. Then, of course, the future will be also to put the goggles and having health devices to monitor and the patient maybe off remotely. And then, of course, electronic health record and telemedicine. So it's a complex project, as I said, because it's going to it's quite advanced in the medical remind. It's not a simple building like a clinic, but yeah, this is quite challenging and quite exciting. Then the project that we are currently completed in 24-25 so far, we have on capital side, we got Ladysmith that's been completed. The rooftop chiller is not a very fancy project, but it's very important to keep the air conditioning working at the hospital. And then the new Villersdorp ambulance station. And then, as I mentioned, there is a lot of lift that we have to deal with. So we have on the maintenance side, we have the maintaining of George and Tageberg lift, as well as the Clothersville CDC general maintenance. Some photos of the project. Ladysmith was completed recently, as I mentioned, will be fully operationalized by the end of September. We have some issue related to connection with the water, electricity. This is the budget that, or the project cost that was almost 25 million rand. And these are was implemented by the Department of Infrastructure. As you see, the building it can provide. This is our we have a typology site or layout for clinics below 1,000 square meters. So you will see that the new ones, they got similar kind of layout, because of course we are learning all the time, but we don't reinvent the wheel for new projects. Omri, this is a quite nice project because is a high demand, because it's the facility, the area is under service. The municipalities offered to us a 99-year lease for getting a taxi rank that was not used by the taxi association. So we checked the taxi rank building, but then was found that was not suitable for the clinic, so we demolished it. And then we rebuilt this clinic, and hopefully we will close the construction in February 2026. And the cost is much higher because I mentioned it's more challenging. The site is not an even site, so and then we had to do all the demolition, and of course there is escalation cost for the project. Then currently in construction, we have a capital project that are 17. I'm not going to read all of them, but we have, maybe what I can mention is the project that we have at the two hospitals, the acute psychiatric unit, the Esterefier and Calicia, that will be completed hopefully by the end of February 2025. Then Revesmith is a contractor started recently, is the consolidation and relocation of the current Revesmith, and is going to be much larger than what we have at the moment, and because it's taking also service from the city, one of the City of Cape Town facility, and as you see, the project cost is 100 million roundabout, and will be completed also in June 2026. Then Esterefier, this is the acute psychiatric unit that I mentioned, to be completed in February 2025. That is an independent unit because this needs to be not linked to the hospital itself. And then the other one is Somerset Hospital. That is quite challenging because you can imagine the site is very tight, and also the logistic around to access for material and so forth was quite challenging, but is progressing well. All these psychiatric units they have 40 beds, so this is a standard for the psychiatric unit. Then ready to go to tender is Hanover Park, a new CHC. And is going to be relocated 1 kilometer where the current clinic is, and it's going to be quite a large facility. It's going to be a 24-hour facility, and this is the image of the Hanover Park. It's around about 10,000 square meters, if I remember correctly. And the building grade that you see are the MOU and the emergency center, because a CHC needs to have a midwife unit and then also the emergency center. This is another view of the Hanover Park. Then this is another one quite nice. It's you will see the curve here, but I couldn't convince the architects to change. But nevertheless, this is Veltefrieden. It's in Mitchellsplein. It's going also to be a consolidation of 2 or 3 facilities. I don't remember exactly the number, but it's going to be a big facility also. It's going to be a day facility, and it's going to be built close to the Veltefrieden police station. And this is an image of is out to tender at the moment, or yeah, it's out to tender. So it will start construction soon. And then some maintenance project that we are working on, and you will see the name of Tageberg coming up because I mentioned that we are trying to keep the current building up and running until, but the 2 big hospitals that require a lot of maintenance. And then these are projects that the National Health is doing on our behalf, because the National Health Department, they got what they call it Health Revitalization Grant in kind. And they are the project sponsor. But we have a big challenge with this project, all of them. There is not a lot of progress. But yesterday we had a meeting with the National Department and with their implementer, that is IDT, where they promised us to come up with a plan of action in 2 weeks' time on how to restart the construction happening in this facility. So we keep our finger crossed. We hope that they can actually give us a positive response. Then we are very lucky because we have a lot of interest from the private sector in providing us what they call a donation in kind. So they are responsible, via a process that is also via the Provincial Treasury, Department of Infrastructure, but actually the donors is responsible for the design and construction, and then donate to us the in-kind that is the building. A good example is the Red Cross Children Hospital Trust that has been working with us for the last 20 years or more, where they're actually responsible for all the project, most of the project that are capital project at the Red Cross Children Hospital. Then on climate change, I'm not going to I'm not going to discuss details, but what we are working on is we have a provincial climate change response strategy and implementation, where by 2050, we need to be a net zero province. So we are working on that, and all the money that we can use in order to make our facility less reliant from fossil fuel, more efficient in the use of water, and reducing the greenhouse gases is actually what we are working on. Then what we do, these are just practical projects that we've been doing for the last, I would say, 10 years, is to install smart metering for water and electricity, then to have a proper energy audit to understand actually what is the facility, especially the hospital, they are major consumer of electricity. Then, of course, the Energy Save Initiative. There is a lot of behavior change that is required. We were very successful with the water during the water crisis in 2017. And of course, last year with the ESCOM, as soon as the crisis is over, there is a lot of work to be done in order to keep the awareness up in the agenda. Then the borehole, we installed quite a lot of borehole during 2017, and some of them that they need a treatment plant like Tageberg, where we have water coming from the borehole that is utilized by the hospital. The photovoltaic I mentioned. And then last year we had this project for 47 clinics and 1 forensic pathology, where we put the hybrid inverted backup system. We didn't put solar panel because we are still struggling with the security and safety issue related to vandalism. So we are quite cautious to go for a big installation in clinics specifically because they are not multi-story building. And we try to get this, but they are compatible to have the solar panel to be added at a later stage. And then we have a contract in place where we have, we call it, is called the ESCO contract, where actually a service provider come to assess the facility, look at what potentially can be done in order to reduce the energy. They put the capital cost for all this improvement, and then the saving on the electricity consumption is shared between the service provider and the hospital in order to repay back at the long period, I think it's 10 years period, the capital investment. So we did it in the last few years at Red Cross, at PARL and East FIA, but we are looking at other facilities. Safety security, just a little bit of feedback on this one. We have, as you are aware of, we have issue about the red zone, and we experience now consultants and contractor that they don't want to go to work in some areas. Actually, yesterday, one of our technician in the clinical engineering in Woodwood was hijacked in Mufuleni, and they stole. Thanks God, his arm. They didn't no violence on him, but the GG vehicles were stolen. So this is one issue. Then we have to deal with extortion, that the construction mafia, that is coming to our view at the moment, and we have to deal it as a provincial government quite strongly. Then, of course, we need to do, we are dealing with community arrest when the community is not properly, doesn't know what is going to happen, and the expectations are different from what we are planning and so forth. Then the vandalism and crime is, as I mentioned, and then we are spending a lot of money as a department in look after our facility and staff with the security contracts. And then what we are doing as a way forward, we are working, not that we start, but as I mentioned, the standardization is happening. The clinics under 1,000 square meter are practice standard. We are working to replicate project design in different areas, because CDC can be relocated in different areas with the same kind of design to try to reduce the timing for the design. Then, of course, continue updating norms, standard, technical memorandum for, especially in relation to energy saving, water saving, and so forth. Then we try to work together with the implementer. We work to try to make this working relation improving all the time, and try to be more collaborative, more can say effective and efficient. And then the monitoring on the results. So this is a continuous learning, not to look at mistakes. Everybody make mistake, but that we can learn from the mistake. And I think this is the last one. Thanks.
Thank you very much for the detailed, insightful presentation. Ma'am, what's your title again?
I'm Chief Director for Facilities Infrastructure Management.
Minister, I think we're in good hands. Professionally, we are in very good hands.
I'm an architect, but I'm from Italy.
Uh-huh.
And I am, in Italy, I'm an engineer, and I got a PhD in engineering. So this is why I'm a doctor. But in South Africa, I got the registration as an architect.
We can see it, we can hear it, we can follow it with all the challenges faced by this department. We do see the light at the end of the tunnel, but it's got to be a hands-on deck approach, especially from both sides of the chambers, professionally as well as politically. Members, there we have it. It's now time for dealing with the good and the bad. For the members online as well, it's time for questioning and answering or comments, whatever we want to add to what we've just heard. I'm opening it up. Member van Minen, Member van Wyk, Member Stevens, and our most experienced member there at the back, Member Volker. And I see online as well, Member Jacobs. We will go in that sequence. Member van Minen.
Thank you very much. And thank you very much for the presentation. I mean, I think there's some very big builds. I mean, obviously Tygerberg is enormous, but I mean the others as well. These are serious builds. These aren't just clinic renovations. So I've just got some questions on that. We heard, I think it was last week, from Dr. Kluter about the effect of the budget cut last year and the financial constraints and having to run a much leaner operation. Now, obviously, build is different to operations, but I just want to know if the enormous cuts have had an effect on the scheduling of these builds. Have they resulted in you having to put certain renovations or work on the back burner, so to speak? Another issue, if one looks at things like NERSA increases, if one's going to be hit with a really big electricity increase, is that going to have an effect? Because, I mean, you were talking about, I think you said at Tygerberg, there's 66 lifts. That's a lot of plant. I do assume that in terms of the green technology or the inverters, you do have a system whereby if you are hit by a power outage, those lifts would at least be able to operate to a certain extent. Then one thing I really want to talk about, you had the slide on crime and the challenges that brings. And I know from when I was in the city dealing with health that crime really was a huge issue. Now, for example, with the Klipfontein hospital, you're going to be demolishing, or province is going to be demolishing these schools once they're relocated. Do you need to bring in contingency plans for ensuring that that land is not subject to potentially invasion from people or some sort of ingress? So is that also something you need to take into account? And then just lastly, the Helderberg Hospital. I know 10 years ago there was still talk of relocating it. I assume from looking at the scheduling and having seen what's happened there, particularly with the trauma unit, that has now been pretty much got rid of, and you're going to be retaining it on its present site. Thank you.
Member van Wyk.
Thanks, thanks, Chair. I think, first of all, Member van Minen has probably dealt with quite a few areas that I wanted to deal with, but I think thank you very much for that presentation. I think it is it's obviously a very complex set of work that you need to undertake over the next period of time. So I think just in adding to some of those questions, it's really that how does your funding, how's your funding going to be impacted going forward? Because I think in separating your normal operations from what you need to do on capital, and I think here we sit on the capital works, which are, I would imagine, absolutely essential in terms of where we are sitting in terms of current facilities, in terms of in-migration and the new facilities, end of life, and all of those issues. So, because to me, what's happening in the fiscal constraints and the budget we're just talking about one globular number. And we are not taking into, or at national level, they don't seem to be taking into account the fact that there's this provision that's got to be made for capital and for maintenance. And in your game, your maintenance is of absolute critical importance. And I think, as you've indicated, on the work that's got to be undertaken there. So whether that has been identified separately in the arguments and the debates that need to be taken up with National Treasury and wherever else, because my big concern is the country's painted itself into a corner, and in education we've seen it, and in yourselves at health. These are very critical areas that I don't think we can underestimate that. And how one deals with that, because these are very, very complex projects that you're busy with, and if one's not careful, you're going to get a slippage of a few years on something like that, and it's going to cause major issues going forward. So I think there's got to be some contingency, in my view, that's got to be built in on how we deal with the capital. I think our colleague has mentioned some of those other risk areas of the big expenses where those are going to come. I suppose my other concerns are the other hospitals, the other areas, and I know in George there's a lot of pressure building, even from your own staff and senior medical staff who have actually reached out to me when I was mayor there about the concerns that they have. And to some extent, there are green shoots there that are private sector willing to get involved and looking at those creative solutions. And I know with the George Hospital Trust that has been formed, look, it's probably small change worth of money that they've collected. But the principle there with the new Mediclinic coming in has been the whole thought process that, and some of those trustees have already engaged with Mediclinic, whether it's Mediclinic or Rembrandt, who are the owners of the property, and owners of those hospitals that will now be vacated to the new Mediclinic. And for instance, the Geneva Clinic, to convert that into a children's hospital and almost do a replication of a mini Red Cross hospital and get private sector and get donations in, that will then free up space within the current provincially owned, the regional hospital, to be able to do expansions on an internal basis there. So I'm not sure to what extent those discussions are taking place and how to pull in private sector into this area, because I imagine the next 5 years are going to be pretty rough in terms of your budgetary allocations. So we're going to have to find some form of solution there and reaching out into a broader field for that brain power, new ideas and new funding sources in what we're doing. Thanks.
Thank you, Member Van Wyk. Before I give over to Member Stevens, Member Van Wyk, maybe you also, just for historic information for the Minister and the Department to be aware of, I remember when you were the mayor in George, you had a discussion with me because you've mentioned expansion for the possible public hospital. Maybe you just want to mention the idea you had with, I think it's the old magistrate house. Just for you, Minister, to know. We know there's no money at this stage, but it's also good to know that possible expansions there might be similar to what is happening in Belhar. Thank you.
Yes, I think that's important, Chair. Joining the land of the regional hospital is land owned by Public Works. And on that property is what's known as an old magistrate's house, a derelict house, because it's been vandalized and it's been occupied by homeless people and been severely damaged. And it is a major eyesore for citizens around the area. I know from coming out of hospital personnel, one of the visions was if that land could be incorporated into hospital land, and where the future expansion takes place of that George Hospital, it would move in the direction of where that property is. There's a stream in between the two properties, but there are certainly certain facilities that could then be located across the stream on this other property for that level of expansion. And I think what's probably more important, I know you've probably got a full plate of work for up till 2033, but beyond that, when further expansions come, that one at least can secure the land and make the land safe as such, that it is then not, that one doesn't sit with a further problem that one's going to run out of land in what needs to be done. Now, for instance, on part of, on the hospital side, the helipad is located, and the expansion from where the pediatric wards are, it would be in the direction of that boundary line, and naturally there's certain facilities that then could be moved across, possibly across the stream, to enable the precinct of that hospital to be able to expand. So I think those are some of the thoughts, because naturally what has taken place as well are, where does one put additional housing and so forth. And I think from a hospital precinct area, that accommodation for staff and for, that land would probably could be used for that as well, without sitting with a particular unique problems and very difficult problems that you've had in some of these projects that you've outlined to us. Yeah. Thank you.
Thank you, Member. Member Stevens.
I've just got a few questions to reference the projects in infrastructure progress on page 46, I think, from Parkdean to Riversdale, the challenges. Could the department clarify the specific reasons behind the delays in starting the infrastructure upgrades for the clinics? Are there issues related to contractor performance, procurements, processes, or other logistical challenges? What contingency plans are in place to ensure that essential healthcare services are not disrupted due to these delays? How does the department intend to mitigate the impact on communities that rely on these clinics? Considering the critical importance of these upgrades, what measures are being taken to hold the appointed contractors accountable for the lack of progress? And what alternative strategies are being considered to expedite the work if these delays continue? Then the last point I want to make now. This morning on my way to work, this was on the news, that the Karl Bremer Hospital is a big challenge at the trauma unit where only serious cases can be helped, as they are overcrowded and minor cases cannot be helped. This is a serious matter, as minor cases develop into serious cases. Because we had a little girl, about a month ago, so a little girl from Kraaifontein, 7 years old, that fell in the street. And the mother went twice to the Kraaifontein Day Hospital, of which she was every time sent back only with painkillers. The third day, she was rushed, the mother rushed her to Calbrema Hospital, also where they actually had to wait their time or the chance to be helped. By the time the little girl was helped, she passed on, 7 years old. So that's why I'm saying, this was on the news this morning, it was bothering me. And between all the accidents that happened on the road, even this morning, that is actually bad. Thank you.
Member, the minister just want to know on which radio station was this announced?
This morning on Heart 104.9. Yes.
Thank you for that. Member Van Vogel.
Chair, I thought that the minister and the team will take the first round, but you are the chair.
Oh, okay. That's where one can buy experience. Thank you. Thank you for that. That's why I know that you're the most experienced member here. Maybe let's I'm going to take the advice. Can we have responses, Minister? Then we will then go to the second round. Thank you for that advice, member. It's Women's Month. I take the advice.
Thanks, Chair, and to the honourable members for the questions. I'll just give some sort of high-level remarks on the questions posed, and then we'll go into the details. So, I mean, funding was a question that came up in many of the inputs from the members, and this is something that is a concern and something we're working on with a lot of energy and vigour. So, on the one hand, we do need to look as a country on how provincial infrastructure is financed, and in particular, growth provinces. Because the equitable share doesn't fund that kind of growth, and you do need to fund growth because actually that's how that's how the sustainability is brought into the picture. So while those conversations are taking place in the Budget Council and so on, we kind of shared some insights last week on how we're looking at alternative financing or blended financing to be able to meet these needs. Utilization of the BFI, for example, is one way that we can blend financing, but as a province we also have to add financing, and that's where it becomes quite tricky because our budgets are under so much pressure. And of course it's one thing to build the infrastructure, but it's another thing to make sure that we have the operating budgets to go with it, because you can't build if we can't make sure that we've got doctors and nurses to fill the infrastructure. So those two things do have to go together, and that does create delays. And it does also then mean, as Dr. Angeletti Dutoy mentioned, that certain of these projects will have to be phased in. We won't be able to fully operationalize in one go because we don't have the operating budgets to go with it. Which means we wouldn't have full 600 beds, we'd have 400 and then grow as budgets allow. So funding is an issue, and I'm sure there are more insights that will be shared by the team. Related to this is about how we partner, and in this way we've also got a lot of strategies to do that via the funds, and then also how we partner with the private sector, and there were also questions related to that. So we are developing a strategy on how we work better with the private sector so that we can expand access. And this work will focus on a strategic level, on a technical level, and then also on what are those areas where we can more immediately collaborate and incorporate some of the models that were used during COVID, and how do we apply those to more normal times and in specific ecosystems. So how, what could that look like legally and also within the budget constraints, and it makes sense for us to partner and gain efficiencies in that way. The other thing that we're doing is just lost the word for it. It's consolidation. There we go. Where we take multiple smaller buildings and then build a bigger one, and through that consolidation we gain efficiencies. So we're able to provide more services without the commensurate increase in the operating costs. Then just to mention, there were some slides on green innovations, but I must say that what the department is doing on preparing for climate change and to mitigate the effects of climate change and making sure that we have responsible operations is extraordinary. And it might be worth at some stage in your program having a briefing on it, because there are such fantastic projects in the works. Of course, with the time constraints today, we couldn't really go into all of them, but it's about, how we reduce waste and medical waste and how we greening our operations and so on. It really is quite extraordinary. So I would encourage the committee to have a look into that. Then with that, I'll hand over to the team. Thank you.
Thanks. Thank you, Minister, and thank you to the members for the questions. I'll augment some, particularly around financing and contractor management, and then talk a little bit about safety, and then the team will pick up the bits and pieces that I don't do. So the Minister has covered us in let me say it this way. The financial envelope that has been defined for the public health sector, and in fact for the public sector in general, is something that is completely different to what we've previously been used to. And the National Treasury seems to be on a mission to balance the budget as best that they can. And there are intended and unintended consequences of that. That means that we need to fundamentally change the way that we view how we're going to fund healthcare, and the allocations that we will get. So to be specific, provinces can't borrow, departments can't borrow. So when you want to borrow, when you have large infrastructure, you generally want to borrow. So there's a restriction, and certainly within a departmental level, there's a slightly lesser restriction at a provincial level. And a municipal level, it's much easier to borrow because there is a potential for commercial return. So lend me some money to do some infrastructure on the sewage or invest in electricity, and there's a revenue stream that's going to come. Now, we don't have that revenue stream. We don't charge. It's not our primary focus. So therefore, when you go for a commercial return, the commercial return that you're talking about is something that is beneficial for the entire country. So more healthy people are going to more working people, a greater tax base. So therefore, the money for these large infrastructure projects must come from those people that can borrow, because there is lots of money in the system. So when we did when we went to the financiers for the PPP to do some market sounding, we went to all of the big borrowers, all of the big banks. They were all very positive to say that there is definitely money in the system. We will syndicate it. There are a whole lot of things that we will do. We'll spread our risks, but we are comfortable that there is sufficient funding in the system. In fact, I didn't think that it was a particularly big project in the greater scheme of things. Now, for us, it is a very big project, but in the greater scheme of things, if we're talking about between those three projects, probably 20 billion rand over the next 8 to 10 years, it's a lot of money for us, but in the nationals, in the national narrative, it's not huge money. And so we need to be very clear about how we change the narrative and how we access alternative funds. And the BFI is one source. We've submitted for the HT claim, HT for the PPP. We are getting some very positive feedback on that submission. But one of the things that they do want is they want to see some, and we call it skin in the game, from the province. So now we've got to determine with them exactly what that is. Is it 5%? Is that 10%? Or is it 20%? Is it 25%? Because then we can start going and asking for alternate sources of funding. This is where I then will bring in the private sector. Because the private sector will give you money once off. They won't give you recurrent costs for operations. And so it's all good and well for somebody to say, here's a facility, and then you turn around and say, okay, so how would you like us to operationalize it? And then you get left with a white elephant. And the privatization is a difficult conversation for us to have, because your access to resource does not determine your access to care. It's your clinical condition that determines your access to care in the public sector. What I will give assurance on is that when we start building something, we know that we have got the budget for it. So within the Program 8 infrastructure budget, we have a fairly decent idea about what our budget is for 3 years, and we start with a zero-based budget every year. So you know what your commitments are, you take all of your commitments off, and then that gives you an amount of money that you can then move things from planning into construction, etc. And so we do that, and that then does have an impact on the prioritization. Because, I mean, as Laura showed, there's always more priorities than money. And therefore we balance that up. But at the same vein, we got money for Klipfontein and Belhar for the planning from the BFI. That money was given to us, and in fact there is sufficient money over the MTF to continue to get to a place where we can get to construction. But the next question then is, how do we then fund the construction? But we are not going to pull up the handbrakes now and say, well, we don't know where exactly we're going to get all of that money for in the next 10 years, which is outside of this MTF, and therefore stop doing everything now. That wouldn't be very clever for us. And I think one of the big issues within the infrastructure space is around having shovel-ready projects. You can't have a shovel-ready project unless you've done all the design work, all the engineering work. And I think for the first time, Member Wimpoegel, you will see detailed designs on what we are doing at Klipfontein and at Belhar. Now, we've never had that, because we've always reported back to say we've appointed a PSP. Now you can visually see what the PSP has done. So we can start having those conversations. We can start visualizing what needs to happen. We can start having the next level of engagements, while then also being able to go to the financiers and say, okay, so here it is. Here is the costing. Here is the anticipation of professional fees, construction costs, health technology. Who's going to help contribute to what? And those are the kind of conversations that we have. We are having those conversations. Security. So the effect. I mean. So when we have input cost increases, so the next 40% from Eskom, whether it's 40%, whether it's 8%, we are still going to be in a deficiency, a deficit. Because as I reported back the other day, we're getting 0% inflator on our goods and services. And so it doesn't matter. It's just the problem just gets bigger. It's still a big problem. and I think the reality is the funding that we are getting, we're going to have a very serious conversation of what the benefits package that is funded in this country is. Because we cannot be all things to all people. That said, we cannot be looking at it just through our budget. We need to be looking at it beyond that, to the resourcing that is put into the healthcare needs of the country. The crime is a big worry. It was Walter Vreden, huh? So we had our first direct impact from the construction mafia. We've had direct impact, indirect, and the construction mafia is an amorphous term, and you can never quite pinpoint it. But we've had conversations. I mean, the City of Cape Town has been dealing with this, and we've consulted with them. Laura indicated we really need a whole of government response. And when I talk about whole of government, that just isn't provincial government. There's police, there's criminal intelligence. We really can't be trying to fix this problem one step at a time. And if I see also, if I look at some of the news reports at the moment, we're seeing that there is emphasis much broadly on tackling this to mitigate this risk. But it is a real problem in terms of actually being able to deliver infrastructure. Helderberg. So Helderberg is in the picture, is still in the picture, but we've got quite a big picture at the moment that we need to we are being ambitious in what we're aiming to deliver. But Helderberg definitely is still in the picture. Transport Public, the Department of Infrastructure have secured a site. So a site has been secured. And so with the lessons, hopefully the lessons that we learned from the 2 regional hospitals and the design that we're putting in now will help accelerate ourselves into that particular space. George, so there's been a lot of conversation around what must happen in George, including what happens with the Mediclinic when it goes empty. And again, the issue there is around resourcing. So we won't build things. So we won't build things unless we know that we've got the operational costs to build it. And I'm afraid when I'm looking at the reality of what's going on, and heaven help us now, I mean, what's happening with the statistics is causing me a grave deal of concern, because they are massively impactful on our allocations for health. Massively impactful in terms of the elements that go into the provincial equitable share. So we won't go into something that we don't know that we have the operational costs for. But we have, and we do a lot of, there are opportunities. So Member Van Vogel will remember that in series they closed the private hospital, Witzenberg, and they offered it to us at a much discounted rate. It was an opportunity that literally, it fell out the sky. And we were able, because we were able to motivate, and because of what was happening with the population movement, it showed that funding had to go into the Witzenberg area. And so an opportunity arose, and we've taken that opportunity, and we are now incorporating that into a comprehensive service offering. So a similar thing could happen in George, but again, it's to do with the funding and what is and isn't available. I also think that the package of care becomes quite important. So we won't be having children's hospitals left, right, and centre. There's a very defined package of care. It's set out in Healthcare 2030, and in this period we will actually come to this committee, as Dr. Kluti said last time, and we will present you what we believe our Healthcare 2050 vision is going to be. And that healthcare infrastructure is a major bedstone or corner of bedrock of the Healthcare 2030 and the Healthcare 2050. Lara spoke about the bed plan that was approved at a cabinet level. That's kind of how important these things are, and there will be a new bed plan that will be put together in terms of that. The question about contracted delays. I mean, you asked a whole lot of things, but basically you were asking us, how does this impact and how do we manage our contractors? So we take contractor performance very seriously. Where contractors aren't performing, they are managed. We take the guarantees, we call up the guarantees, and we try and not delay for a particularly long period of time. But there is a reality that the skills and competence are being and have been diluted over a long time. So there's quite a bit of development that has to happen with contractors. So we also engage quite heavily in contractor development. I think one of the funniosities, the interesting things is, for example, if the national department is doing work, then they're managing the contractors. It's not we don't have that contractual relationship. When our implementing agent is building on our behalf, We don't necessarily have the contractual relationship with the contractor. They have the contractual relationship with the contractor. So we almost become at the mercy of others to manage on our behalf. Now, we've got a framework agreement and we've got a number of management contractors where we now, over the last three or 4 years, have been doing direct contracting. So we are then able to turn around and say, hang on, all right, now the contract is between us and you, there's not an intermediary. And that is helping us manage and deliver infrastructure projects. But it's not an exact science, it's not perfect. And there will be delays, there will be poor performance, just as there is very good performance. And I think if you look at the quality of the infrastructure that is delivered, the regularity, we don't bite off more than we can chew. We are very, very realistic in terms of what we're doing. The Carl Bremer, I mean, it always pains me when I sit here or in my office to hear of where the system has failed the citizen. And you just reflected on a tragic event where somehow we failed. And we must learn from that. We must learn from that failure, because the concept around a trauma unit and an emergency center, we should and we can only really see patients that need to be seen. So the triaged, if you're red or you're orange, you should be in there. If you're green, it's really an appropriate place for you to be treated. And in that, unfortunately, sometimes what happens is green becomes yellow, so it becomes red. And that is a tragic set of circumstances. But a lot of this is to do with education. A lot of this is to do with putting in the structures around. So Laura spoke a lot about CDCs and CHCs. So these are facilities that are able to take more people away from the emergency centers, so that the right people are going. That's around putting infrastructure in place to support the design of and the referral pathways that are needed within our health system. And that's what we aim to do. We don't always get it right, and it's obviously tragic and sad to hear when we don't get it right. I think I've answered a number of them, but I'll then ask Dr. Angeletti Toy if there's anything she wishes to add. Thank you very much, Chair and Minister.
Okay, thank you. On the Cliffontaine invasion risk alike, what we have been doing in the Guguleto site, where we have also high level of risk for invasion, we have a constructed the fence, and is highly security fence. Sorry, Hanover Park, no Guguleto, apologies. Apologies, it's Hanover Park. And we have also worked with the City of Cape Town and their law enforcement to be able to patrol the site. So the idea is that with the assistance of community, the assistance of the City of Cape Town law enforcement, and with a proper robust fence, we can mitigate the risk of land invasion. But it's a really high level it's a very real risk. On the land owned by the Public Works in the George area, close to the hospital, we have been, I think for the last 2 years, discussing with the movable asset team from the Department of Infrastructure, because for any acquisition of site, we need to go via them as a custodian. They wrote a lot of letters to the National Department of Works, but they haven't received one reply. And recently they said to us what we do now, because we continue to write letters, but there is no feedback from the National Department. So what we also address is the fact that the Magistrate Court is a historical building that is required a lot of restoration according to the heritage legislation, and moreover there is people that currently live in there. So we see a lot of red flags in that. So we said to the Department of Infrastructure, okay, let's leave it for the moment, because we tried, and I will say we tried for at least 3 years. Because we were informed by the CEO of the hospital about that site, and he was very keen to come and take in for the expansion of the hospital, but we couldn't get any response for the national. We actually work with this one, with the office in Cape Town and also at the Pretoria level, but we didn't get the feedback. So maybe we can try again soon. Okay, that is one. And then your question, honourable member, about the DOI, the National Department projects in the garden routes. It's a very interesting story. I will try to make it, it's quite complex, but nevertheless, this project is implemented by the National Department of Health, all of them. They appoint consultants, and I call it consultants A, to do the design. So they did, and they're progressing quite well. And they appoint IDT as implementer. There was something happened between the consultants A and the National Department of Health, but I'm not aware of the reasoning that the Department of National Health didn't pay fully consultants A. Okay, so the consultants A were not paid fully, and yesterday we heard from the team that is something like around about 2 million rand that are outstanding on fees. The National Department of Health terminated the appointment of consultants A, and they asked to IDT to appoint consultants B, okay? So the consultants B, they went to the consultants A and they asked for the drawings because they've done a lot of work. And the drawings were, they said, and the consultant A said no, because we are not paid. So the contractor in the meantime were appointed, I'm right. And the contractor, and this is why the contractor were appointed, but they couldn't go on site because there was no principal agent, there was no finalization of the drawings and so forth. And now, yesterday we heard that the consultants B has asked to IDT to terminate their appointment because they are not capable to complete the job. So this is the two, so the contractor is not responsible for this debacle, is actually the National Department of Health that needs to solve the problem. And this is where yesterday we were asking, and they said to us 2 weeks for a plan. But unfortunately, it's outside our control. We rented some, if you go to site, you see there are some containers that we rented for, and there are provincial money that we are paying for renting these containers. And yesterday we said to the National Department, we are going to move out of these containers because we are wasting money in the province. So when the contractor is coming and you have clarified who's doing the job, you will be able, you must do the containers. So it's a very, very painful kind of experience, yeah. Then then I think I don't have any, the Prefontaine I mentioned, and no, thank you, that's it, thanks.
Member Van Vogel, do you mind if I give to Member Jacobs, who's online? Member Jacobs, you can go.
Thank you, Chairperson. Am I audible?
Yes, you are. Go ahead.
Thank you, Mr. Chair. I just made a couple of notes here, so I've just got a couple of questions that I need to ask. Mr. Chair, I'm gonna go directly in. I've read through this proposal or to this document that I got, and then this is a couple of notes that I made. So let's start with extortion. Can we as a portfolio ask the department to at least make sure that when it comes to the building of any health facility, can we at least make sure that we put the 30% back as it was before 2005? And I'm going to tell you why, Mr. Chair. When the Mitchells Plain Hospital was built, we were all a part of it. There was a 30% that was put aside for the local contractors. Yes, even though there was a little bit of trouble, but because of the 30%, the project ran smoothly. Now, I've been around for many years, Mr. Chair, and I've been to many facilities, I've been part of many project steering committees. Wherever the 30% is included, you won't find people just extorting. And sometimes when we speak about extortion, Mr. Chair, let me just quickly enlighten the House. There's many projects that came here. Then the local contractors will go for work. What the contractors then do is they say, yeah, but these people, they extorted us. Remember, when the contractors start, they get a percentage of the money. What happens then is they move. They take the deposit that they have and they move because now they fear for their lives. But in the meanwhile, it's not contractors that is actually extorting them. It's only people that is really coming and asking for work. That is really what's happening. So if we as a department can make sure that we add that 30% back there, our facilities will run without construction mafias. And then also, Mr. Chair, what I want to ask is what I was also focusing on is I see that we
Sorry, member Jacobs.
Yeah.
Just for me also to understand the context. Are you saying that 30% has been taken away?
30% has been taken away, Mr. Chair. There's no 30% added in none of the contracts that's going out. Hence the reason we got all this fighting. Hence the reason we got people coming asking for work, and then they are being considered extortioners. It's happening all over the place, Mr. Chair.
And so remember, Jacobs, the 30%, is it the referral to the triple BE component of it? Is that what you're referring to?
Yes, Mr. Chair, for the local contractors.
All right,
The
thank you.
30% that was always put aside. And I don't want to make this political, Mr. Chair, but the
All right.
reality is after the new political party took over, which is obviously the Democratic Alliance, that 30% was totally cut out. And since that happened, we've got a lot of problems with extortion. But let me continue, Mr. Chair.
Yeah, I know, Member Jacobs, we understand the content. You know, we just wanted to understand what you're referring at so that we can respond appropriately. Thank you. You may continue.
Okay. And then I was focusing on the facilities, Mr. Chair. I see that we build a lot of facilities, but we build the facilities without resources, without the human resources. I'm going to make an example. I went to Verliesdorp. Remember, I got you there. Then I had a little word with some of the people there. I spoke to them and they said, you know what? Yes, we have this nice facility, but we only got one ambulance here. We are understaffed here. And they told me just 2 weeks ago, because of them only having one ambulance, they lost a police officer because there wasn't another ambulance. The one ambulance was already out. So my question is, are we putting up nice facilities? Or are we really making sure that we are putting in the resources and the human resources? That is just one thing that I've noticed, Mr. Chair. Then also, I wanna bring this also to the House to say that it's important for us to go to the couple of sites where they are still busy building, because when you go to these sites, you will find that the majority of the people working on these sites is illegal foreign nationals. I drove through, I went past Grooteskiel Hospital because somebody phoned me there. I went there. There was a whole line full of foreign nationals all applying for the security job. So this is just something that I made a couple of notes of, Mr. Chair, and I really want us to look into it. Then when it comes to the Klipfontein Hospital, Mr. Chair, what I noticed was the Silver Stream School will be moved to the Menenberg School of Skills. Now, my question is, where will the mainstream learners go? Will they also be accommodated? Because remember, everybody is not really going to. Remember, School of Skills is for people that need a certain skill. What happened to the mainstream learners? Will they be accommodated? Remember, Klipfontein will be built in 3 phases. No? The first phase will be completed in 2023. This is according to the report. Now, if the first phase is going to be completed in 2023, Mr. Chair, is there a way that we can put alternative measurements in place to alleviate the pressure that is on the Mitchells Plain Hospital? Mr. Chair, I can show you now a lot of screenshots. Our people are dying at that hospital. The hospital in itself is understaffed, Mr. Chair. There's a language barrier there, Mr. Chair. There's racist problems within the workspace, Mr. Chair. So my question to the House is there any way that we can put up temporary structures? And we can't say we can't do temporary structures. When we look at Mitchells Plain, the education department is just putting temporary structures up here as schools. Can't we do the same just to alleviate the pressure? Not just Mitchells Plain, but Kailitsa, Grooteskiel, all these hospitals, Mr. Chair. And then Last but not least, I see the house as there's completion dates there, but then they're still talking about we're looking for money. Now, I want to say, Mr. Chair, we must learn from this. We must learn that we cannot give money away from such a critical department and give it over to failing departments. So, yeah, that is just my 2 cents. Thank you, Mr. Chair.
Thank you, Member. Member Van Vogel.
Thank you, Chairperson. Chair, let me start by welcoming the presentation of the department. I think I must also start by saying I need to compliment the department when it comes to the facilities in the Southern Cape. And when you compare the Southern Cape facilities to the other regions, I think they are doing very well in the Southern Cape. There was a story saying it's because the NHI pilot project of the NHI pilot was done in the Southern Cape, and that's the reason why the Southern Cape's facilities is actually much better than the other parts of the province. Then, secondly, Chairperson, on slide 13, I think, because there's no numbers really, but I numbered my own. Can the department tell us more about the infrastructure backlog? I think I'm not sure who mentioned or who touched on the issue, and how many facilities are affected. And is the backlog nearly 40 billion considered to be high as per the health infrastructure? Then secondly, Chair, I just want to check because in the past 5 years, in the night, early in the morning, you will hear that there was a fire in one of our hospitals or clinics. Are all our facilities fire compliant? And if not, how many are not compliant? Then, Chair, on the infrastructure priorities, the department's annual report noted that 26 facilities are in a very poor condition, very poor condition. What plans does the department have to address these issues and improve the infrastructure in the province when it comes to these 26, specific when we speak about the 26 facilities? Then, Chairperson, I think my colleague touched on the issue when it comes to the Klipfontein Regional Hospital. Mr. K knows. That's my name for the past 5 years. And I'm really disturbed by the prolonged delay in the building of the Klipfontein Regional Hospital, replacing the GF Hospital. But I'm also excited to see something is happening. And I really hope that, because remember, it was 2020 what, now it's at 3033. And I hope it's going to be 3033, if I'm not 2033. So I really hope it's going to be our timeline of deadline. So yeah, because I think Mr. Jacobs or Member Jacobs have touched the problems that our people experience on a daily basis. When it comes to KDH, Khayelitsha Hospital, Mitchell's Plain Hospital, and Mr. K knows there was a time when our patients slept on the floors, and it was not nice because our people does not deserve such treatment. Then, Chairperson, on the issue of the health facilities platform, I think it's in slide 4. I just want to know, the slide makes mention of PHCs. My interest is on the community health clinics that were transferred from the city to the province. Have there been any infrastructure improvements made or planned? I'm concerned about the lack of adequate waiting areas in these clinics. Patients, including the elderly, often have to arrive very early in the morning and wait outside for hours in the rain and in the sun. Yeah, the weather condition doesn't matter. They have to wait up until our security guards can come and open the doors of the gates. And then obviously the security guards will also decide who comes in and who not, and who needs a doctor and who not. And I mentioned it in one of our meetings, the power that security guards have these days. Yeah, I think I will park there, but then the last part, I want to understand the Lady Smith. I think it's the Lady Smith hospital, clinic. There's a nice building. When I started, I know we were discussing the issue, and eventually the project started and the clinic was built, but now it's a white elephant. If we can just get the reason why the facility is not operational. Yeah, and then, Chair, there was this issue of perhaps what I can do is let me engage the minister after, because I also received now while I'm sitting here bad services from Maritzburg Hospital and then Kraaifontein Clinic. So perhaps I can deal with it, engage the HOD and the minister's office when it comes to those issues. Thank you, Chair.
Thank you, member. Colleagues, also allow me, members, since this is the last round, just to add, Minister, to some of the issues. The Triple P, where we come from at a municipal level, it takes forever. You know, but it probably sometimes takes 5 years just to get a signature, 5 to 10 years. Now I'm excited in terms of the Tygerberg development, the Triple Ps that's happening there, and how did you guys get it right? You know, because I think Member van Binnen and Member van Wyk, we know from where we come from, we finish a term, you know, without having a single signature on any possible partner for a Triple P. So this is very exciting. And then, Minister, this is based on the issue raised by Member Stevens, you know, the sad issue of the 7-year-old. Now, common sense tells you, you know, that there must have been human error in between, you know, and I don't know, but what I want to ask, Minister, you know, we probably might not have the answer here, but it's just something that I've experienced. In California, in the United States, law enforcement agencies have KPAs and KPIs. They will respond within a certain time to an accident, and they will clear it within a certain time. And if that doesn't happen, there are measures in place. I don't know how to put it, but we know at our level we talk about KPAs and KPIs. You know, and my question then immediately would be in the medical field. Does medical practitioners have KPAs and KPIs? You know, because surely to sit in a waiting room from 8 in the morning until 4:30, then you get turned away to say come back the next day. Surely there's a KPA issue there. You know, so the answer might not be here, and it might be escalated, it might be somewhere else, But surely it is an area that I think it should be a discussion, Minister, you know, that at these facilities where we get these horror stories, somebody's in charge, you know, and they say in the practical world, shit flows down, Minister. Pardon my French. But when somebody gets turned away, a hostel has a matron, it has whatever at school level, somebody knows or somebody is supposed or ought to have known that there should be time frames. But that's just for interest's sake, and it's a discussion probably for another day, Minister. But you know, KPAs and KPIs should be taken seriously in all professions. I'll give over, Minister, for response. Minister, Member Van Wyk.
Thanks, Chair. Just maybe as part of this round, and I suppose what just to continue some of that previous discussion. At municipal level, NT imposes an 8% of your assets, in other words, your fixed assets that they expect to be spent on a yearly basis on maintenance and on refurbishment of those assets. Now, while that has been in place for many years, most municipalities were never able to reach that type of level, and today we sit with the problem of crumbling and aging infrastructure and problems throughout the local government system. If one looks at your capital spend and your maintenance spend relative to your total budget, it appears to be a very small percentage. And at the same time, I imagine on the asset base that you have within the system, it's probably also a very pitiful expense. And I think in the arguments that we have and the debate that one has in the predicament, the funding predicament, I believe there should be some set level that should then come in terms of the budgetary amount that you get. So in whatever allocation that gets given to provinces, and I'm not sure whether this discussion has probably been there already, what proportion should then go to that level of maintenance and providing new facilities. And I don't know to what extent that gives any strength to the negotiation, but I think that it is something that in terms of the new era and the complex financing era that we've got to have a little bit of a harder discussion on what is the type of funding that is needed in this space. So that was just my thought there, Chair. Thanks.
Thank you, members. And Minister, before I give over to this last round of responses, as the chairperson, I also just want to emphasize to the members of the committee and for your officials also to understand, Minister, is that some of the questions and inputs, I can sense some boiling in terms of the realities that we see on the ground. But I also want to give the assurance to the members is that although we're from political parties, you know, the issues cut across. It cuts across the boards, regardless of which political parties we represent. In the constituency, the pain is the same, you know, and the plight is the same. And I want to give the assurance that this committee will not get into a war zone with the officials. Minister and officials, please take it from us. That is not going to be us against you and try to expose the political divide. We take it that the issues affects all of us, and some of these issues, members, we will have to have our own tea and coffee when the officials are not present, so that we can deal with the underlying matters that does have political implications in terms of when we're out there in the streets. But please take it from me that it is not going to be a kind of elephant in a china shop, you know, when we engage with yourselves. But I do take to heart that all the questions raised does make sense, and if we work together, regardless of our political affiliations, we can make a difference. Thank you, Minister. Round two.
Thanks very much, Chair. I think what we should do is, I think as representatives of the public, you all do receive complaints of when we don't get things right, or for suggestions of how we could do things better. So I think what would be important for us to do is to share with the standing committee members the complaints details, so that you have the phone number, the please call me number, as well as the complaints email, and the one that also goes through my office, so that we have sight of what some of the issues are, and then they can be properly investigated. And we do have a robust investigation process for when things do go wrong, and to have a look at how they can be fixed into the future. Because that's the purpose of it, is to see how do we remedy some of these issues. So we will share that with the committee, and we'd encourage you to please use those channels and to help us in this regard. Then just to take the question on extortion, I think it's very important to clarify that there is a very big difference between SMME development and extortion, and I don't think it's helpful to conflate the two. Demands for contracts to be awarded or protection fees outside of procurement processes is illegal, and that is not something that we will tolerate. And that is what we're referring to when we're talking about extortion and the extortion mafia. When it comes to SMME development, that is a totally different conversation. That is a lawful support of small businesses in the province. And, I would encourage the honourable member to read the latest annual procurement disclosure report of 2022-23, which is published by the Provincial Treasury, which gives an overview on what public money was spent on. And if we have a look at the latest annual report of the PDR, the total procurement expenditure by the Western Cape government was around 20.4 billion rand. And 41.4% of expenditure benefited SMMEs in that last financial year. So there is a concerted effort to support SMMEs by the provincial government, and I think that obviously construction is one of those areas as well. But I just thought it was important to conceptually separate those things. Then I think I'll hand over to the team on the specifics of the facilities. We've got a number of questions on those. Thanks.
Thank you, Minister. So I'll answer a couple, and then on the technical bits and pieces, I'll refer to the people that actually know what's going on in terms of the detail. I want to start with Member Van Vogel, because we have had a number of engagements over a number of years. So first of all, thank you for recognizing the quality of the facilities that we build. That's when Lara talks about a standard and replication. It is our aim to replicate and continue that throughout the whole province. So thank you for recognizing that. The second thing I want to do is I want to acknowledge and thank you for holding us accountable around specifically Klipfontein, but on Belhar 2 and on Tygerberg, because you always ask us, whenever we come to this chamber, you always ask us for an update, and you always express to us the impact that not having a replacement facility was in that community has, and the impact that it has on the broader system. So had a little bit of a, when I saw Laura's presentation, I had a big smile, and when I went and actually sat with the PSPs, I had a bigger smile, because we're actually now able to show you something tangible. And we've never been able to show you tangible. We've always been talking about planning. And so thank you for holding us accountable, and to continue holding us accountable in those timelines. You will appreciate that there are a lot of moving parts. So a little bit to Member Jacob's question about education. Now, we are not the Department of Education, but we are highly reliant on the Department of Education, the Department of Infrastructure, the City of Cape Town, to be able to deliver these. So City of Cape Town, I'm sorry, the Department of Infrastructure, I'll get it right eventually, the Department of Education will do what is needed for the high school in mainstream, and for those that need to go to the School of Skills. They will move the children. I understand there's somewhere around about 700 pupils in the primary school. They will respond appropriately to the education needs of those children. Member Jacobs, the issue about foreign nationals and a Grooteskeer. So this has caused an enormous, and I think this is what you were referring to, Chair, and it has caused an enormous amount of ruction and discourse. We are required, and our contractors are required, to comply with the immigration laws, and by virtue of the fact that you are a foreign national, if you have the correct work permits and papers in place which are checked, then you are not precluded from being employed. And so I appreciate that, but this particular contract and at this particular hospital, this is not the first time it has been raised. And there were some rather unfortunate incidents that led to police intervention around this. And so I do appreciate your lead in that space. So the complaints, so it's deaths of children, in fact, there are death reviews and adverse event reviews at any adverse event. And these are reviews that are led by independent clinicians to ascertain what went wrong or what went right. There's not always, we mustn't always paint that everything is wrong. I would ask, and I think Member Winful, who you will remember, there is a very fine line between a complaint and then being involved in a patient's personal journey and starting to involve yourself in confidential conversations about medical and clinical care. None of us here are clinicians, so we are not qualified to make comments on these. But I would just ask to just be very mindful about patient confidentiality. If things aren't being done properly, then it is for the patients, the guardians. They have legal course, they have rights, and we have a robust system that deals with adverse events. And you'll hear this thing about medical legal. If we get things wrong and we are at fault, our position is not to fight in court, but rather to mediate and arbitrate. Because what's very important for us is that we have a culture where we don't blame. And if you don't blame, you can solve problems. If you blame, you have a fear culture, and it becomes very difficult to solve problems. And so I would just ask to this committee just to be aware of it, because I know there's a lot of complaints that come through, particularly from this. So timeframes. There's a comment from the chair. So in my experience, the thing that delays projects the most is the planning and the confirmation of affordability. Those are the things that invariably trip us up. And so we're having conversations now about affordability for 2028, 2030. We've got time to get those in place. The Tygerberg PPP has come a very long way, and it always got stuck on an affordability. And when we crack the affordability conundrum, so signatures flow. And so I would just, the issue around Villiersdorp, Member Jacobs, and the resourcing, I mean, I've touched a little bit on the resourcing, but it's fascinating because if you go to what Villiersdorp had and what they have now, it's chalk and cheese. And we went to go and have a conversation and visit the Villiersdorp clinic before they moved. It was very interesting about the question that you ask about resourcing and how you would utilize resourcing. So we were talking to the clinic nurse practitioner, and the clinic nurse practitioner said, "Give me more people because I've got an endless queue." But when you spoke to the medical officers, they said, "We don't need more people. We need the farmers to assist us so that we don't have people coming in to our facilities. We can go out, and instead of them having to come to our facility, we can go and see them in the farms, because agriculture is so important in that area, and there are a lot of partnerships that are happening in that space." So yes, when you experience lots of people coming through the door, your lived experiences, there must be more people to see the more people. But if we can make sure that people are looking after themselves and are taking their medication and that we have improved the social determinants, then we won't have that pressure coming through the door. And and a lot of that is around messaging. A lot of that is around communicating. A lot of that is about explaining where you should be going when it's appropriate. I'll let Laura answer some of the more explicit questions. Thank you, Chair and Minister.
Thank you, Chair. The infrastructure backlog and the FAR compliance, the issue about how many facilities comply, we will provide you the information. A facility is required to have a certificate of FAR compliance issued every year. So we have to keep that updated every year. So we will be able to provide information, but I don't have it at this point in time. And the infrastructure backlog, I can try to explain, is an infrastructure backlog related to capital work that require, like Cliffontein, Tygerberg, and so forth, and is a maintenance backlog. The maintenance backlog is around about 1.8 billion. So if we want to solve all the maintenance problem in the province for the health department, we need 1.8 billion to be set aside only for maintenance, and was your comment also on that. Our budget, including everything, health technology, infrastructure, is between the grant and the PES, it's 1.3 billion per year. So you will see that actually we don't have enough funding to, and this is the discussion on how do you fund infrastructure and maintenance. But the rest of the 39 billion is capital work. So clinics to be built in the right place, hospital to be rebuilt, like Elderberg, like Tygerberg, and so forth. So that is the details. But we can share the draft UMP that is for 25-26. You will now we are working on the new year, so we have 25-26 draft UMP where there are all the details about the backlogs in information. In relation to the clinics, you mentioned there are 26 facilities in poor condition. This is you will if you look at carefully on the clinics or on what is poor condition, means that there are projects that are already started to replace those facilities. So, for example, one of the facilities that we classify poor condition is Hanover Park. But Hanover Park is going to be replaced, and we are already busy with the new, with the tender for the new one. So the poor condition that in the UAMP we call it category 2, are linked to capital projects for replacement or consolidation and so forth. So that is, but we can provide more information, but everything is in the UAMP, so you will see in the UAMP the information. Then the health facility platform, the City of Cape Town, yes, we receive, as you know, 10 of them or 11 of them 3 years ago. And we receive other 2, Saxon Sea and Protea Park in Atlantis from the 1st of April 2024. And you are correct, the facility, they didn't provide the full package of service from the city, so there is some work that is required. So we are working with the substructure to see what is actually the work. We know that Protea Park especially required a lot of maintenance. We had an incident of collapsing of ceiling not a long time ago, and but we will need to extend at least the Protea Park. And the other one that we are busy replacing is the Oat Bay one, where there is that one that is it's a consolidation of a provincial clinic with a City of Cape Town clinic. And we are busy building or designing a new CDC in the middle of the Oat Bay to replace both of them. So it's an ongoing process, and it's of course the criteria for priorities is what I listed before and I mentioned before. Then the Ladysmith not fully operational, as I mentioned in the slide, when the project is completed, practical completion, there is a period where we call it commissioning. And in that commissioning, there is, for example, the installation of network points, because they are not part of the capital work. And there is the staffing training for the utilization facility. There is a commissioning of the equipment that is coming. So at the moment, we are working in that phase of the Ladysmith clinic. And the idea is that they will be fully commissioned, so will be fully operationalized from the 30th of September. So that is the date that we are working on. And on the PPP, I think Mr. Kay has answered. And the maintenance budget, yes, the health facility should have a maintenance budget between 2 and 3% of replacement cost every year for the specific facility. We cannot afford that. We did a calculation. We have 0.0 something, so for each facility. But this is exactly what we try to prevent decay of facility after construction. So we put a preventive maintenance. So you will see that the project that we completed in the last 10 years, they are not properly, not perfectly, but at least they got additional funding for the corrective preventative maintenance. Thanks.
Mr. Kay, may go ahead.
So yes, I wanted to just answer that question as well as slightly differently, because Member Van Wyk, there are competing priorities in terms of a fixed amount of money. And so as the CFO, I always turn around and say, okay, so we want to prioritize this. What are we going to deprioritize? It's a zero-sum game. I never get the answer to that. And therein lies the complexity of a health system. And we must be very mindful about focusing on one particular area, because everything else then there's an imbalance. The reality is we don't get all the money that we want for all things. None of us do. None of us. There's only one Elon Musk in the world.
And he's from South Africa.
And he's, well, yes, and there's, but not all of us can afford everything that we want. That's the reality. And therefore, we are asked to be stewards and custodians of what is given, and then we must be responsible with it. And we aim to be as responsible as we can. We accept that we're not perfect at everything. We accept that we make mistakes. but we learn from those mistakes to improve the service offering that we give. Thank you.
Thank you, CFO. Folks, I've learned two things here this morning, and I think it will take us a long way in future. The first thing I've learned is from Member Windvogel that some things can be taken offline with the engagements between the politicians and the professionals. And Minister, you made mention of a hotline. You know, there are hotlines as well that we can make use of. So the offlines and the hotlines where we can raise the matters, I think that would really put this standing committee in a direction that would take both sides of the chambers forward. And it is something that I will definitely make use of. And for the other members on the fourth floor, I think we must also now get into the culture that you're more than welcome to come up to the fifth floor, and we from the fifth floor will from time to time go to the fourth floor. So I will start bouncing around on the fourth floor as well. And the other advantage, colleagues, before I get my cue from yourselves, the other advantage is that the majority of us in this committee also serve on education, and those are the two biggest headache departments at the moment, Minister. So based on the questions and the comments that came out, is that we can deal with these challenges in both standing committees. The left hand would now assist the right hand, and Minister at your level as well. I know it might be difficult for the professionals to do the same, but at your level as well, we would then have that integration where what can be of assistance in the educational committee can then be conveyed by us as well when we sit in that committee, and to ensure that the two biggest departments in the province, work hand in hand. Now, before Minister, I let you go, you and the professionals, I will take my cue from the members. We're also due for a tea break or a lunch break, and I'll take my cue from yourselves on whether we let the Minister and a team go and enjoy the refreshments and we finalize, or because it's Friday as well today, and some of us are going to the Eastern Cape. Members, I'm in your hands.
I would think let's try and finish as soon as possible.
All right.
Before we break.
I see the women are nodding to that suggestion in Women's Month. I'll take it that.
Yeah, Chair, I do understand we want to conclude our business, but we are not healthy, and the Minister and Mr. K don't want us there. We need to drink our tablets.
Okay.
And go to the loo. So I will request that we at least take the break now. In 5 minutes, we are back.
Member for minute.
Thank you. I've still got to chair a meeting later, so I really would appreciate it if we just finish up. It's not like it's a long meeting.
All right. I don't want us to do this in front of the professionals.
Yeah.
Minister, you and your team, and you may go to the members' lounge along. Go and do your thing. We will finish this in 1 minute now.
My things.
You want to speak to the Minister? Minister?
I think we can just go.
You're offline with Member Windvogel. Okay, guys, can we, sorry for that. Can we make it 5 minutes? Thank you, Doc. Member Jacobs?
Yes, Mr. Chair.
I propose that we're going to finish within 2 minutes, and then we know We done for the day. I only have, from my side, for instance, I have one possible recommendation if we're going to agree on that. Other than that, within 2 minutes we can be done.
Agreed.
Thank you. Member Van Voel, I think we will be done within 2 minutes, promise. Colleagues, any resolutions? I've got one. All right, a resolution from me, PO, is that we probably need to ask the department, I don't know how you're going to word it.
Okay.
We need to ask the department, based on the suggestion made by the minister, on a specific brief or presentation on the mitigating
Climate change.
the mitigating methods on climate change. Then we know in future, then we can then just deal with that.
I think that includes improvements and innovations that they are implementing in the department.
All improvements and innovations, so that would then include this as well. Pio, do you have that?
Yes.
All right, a member Van Vogel?
Then the 26 facilities that is in poor condition, if you can get an update, because I think she mentioned 2 that they are busy with, so if you can get an update in terms of those facilities.
On which are those 26 facilities,
Yes,
and what are the improvements on it? Okay.
And then lastly, Chair, also the Swellendam, if Swellendam is part of those, because I know they are busy, we want, if we can get a update when the facility will be operational.
The one in Swellendam?
Swellendam one, yeah.
Okay. That's noted. Any other? It looks like, we have.
Mr. Chair.
Yes, Member Jacobs?
Yeah, I also just wanted to know if it's possible. Can the department forward us a list with all the contractors that is currently busy on sites?
I'm not so sure. We're gonna make a note of that, Member Jacobs. But I know at municipal level it was always a dangerous thing for us. I'm not sure at this level, but we're gonna note that, and we will rely on the response on whether that is permissible or not. But I know the AG, what's the word? He cut our hands off at municipal level regarding those requests. But we will note it, member. I'm not sure at this level, but we will just take it from there and going forward. Going forward as well, members, is that we're going to deal with everything and anything. We will sort it out politically amongst ourselves and make sure that we are all on the same page. So we're not going to have taboo questions and no-nos. If we don't know, we will put heads together and we will just deal with it. Member Van Vogel, last one.
Yeah, my last one, Chair, I'm not sure how to formulate it, but you are the expert there in front. Given the need for the regional hospitals in the province, why isn't it the department operating the district, like the Kailicha, KDH and what do you call it? KDH and Mitchell's Plain to regional hospital. Why are they not changing that status while we are waiting on the Klipfontein and the Bella hospital?
We'll put that question. Yeah, we will forward that question as well. So colleagues, I think we have reached the line. Thank you very much, and the meeting is adjourned. There will also be communication regarding next week. It might not happen. We might not have a sit down, but the PO will communicate accordingly.
There is nothing, Chair. We are not going to have a meeting next week.
All right. We have a leg stretch next week. We'll communicate if I've changed my mind. Thank you.
Thank you, Mr. Chair. Amase.
Thank you.
by Member Jacobs.
you.